Welcome to Caretalk, America's home for incisive debate on healthcare, business, and politics. This morning, we have as our special guest, Dr. Tom Milam, Chief Medical Officer of Iris Telehealth. Welcome, Tom.
Thank you. Great to be with you, John.
So, Tom, maybe before we get into Iris and kind of all the cool things you're doing and your perspectives on AI and mental health, what was your healthcare journey like? How did you end up as the Chief Medical Officer? What were your ambitions? How did you get here?
And great question. It's been an interesting journey. I've been a psychiatrist for 25 years. I've been on faculty at Virginia Tech, Caretalk in Roanoke, Virginia for the last 16 years. And during about 2016, a little bit earlier, began to see how so much of Virginia, like many states, has a very rural population, and was looking at how my patients were having to drive hours and hours to come to our hub hospital to get care. And I began doing some pilots with various clinics in rural areas, family medicine clinics, pediatricians, seeing patients on site there through telehealth, and developed a network where providers could just call me and say, "Hey, Tom, I've got a patient here. Can you help us out?" Or it's kind of a challenging mental health issue or addictions issue. Started doing that. That turned into getting some grant money to expand it. Expanded it to a number of our emergency rooms at Virginia Tech and the 5 hospitals that we serve. And from that, got really interested in telehealth and the need to provide high quality mental health care where it's needed, when it's needed. And ultimately, in 2018, I was invited to join Iris Telehealth. As I said, it was small when we started. We had about 20 or 30 providers, and now we have about 650 throughout the country, and it's been a wonderful journey.
Well, maybe double down on, with your background as a psychiatrist, how many people do you think who need access to mental health services are getting it, just in general?
Or two parts to that question. Are they getting any access at all? And I would say that probably close to 50% of people that could benefit from access to it, whether they have mild to moderate stress or need help with coping strategies, to those who are really struggling with depression or anxiety or addiction, are simply not getting it. They don't know who to turn to. They don't know the mechanisms through which they could seek care. They don't know what the expense is or whether the insurance is available. So that's a huge part of our population. And I think one of the things we learned during COVID is how many pockets of people there are who have very limited access to any healthcare, let alone mental health care. So there are a number of other folks that need it. They may not know that they need it. The key is with mental health care is that sometimes you don't know that you need it until things get really bad.
I think that's true of most of us, Tom. Let's just be honest.
Absolutely. So that's the second part to it, that once you need it, there has been such a long wait to get it and to get directed to the kind of care you need, whether you need therapy, whether you need some psychiatry or psychiatric medication management. So helping patients with that journey, wherever they are, is what we do with Iris Telehealth.
Well, I think the other, interesting problem you're solving, and you have a unique perspective being in Virginia, which has people think about it as the urban centers and, Metro DC and Charlottesville, but there's a ton of, it's a great example of a lot of the states in the US where there is pretty limited access to general healthcare in rural areas. And I think it's hard for folks in suburban and urban locations to understand how complicated it is if you're working full time in a rural area to then schlep and get care unless it's in an absolute crisis. And I think that's one of the interesting avenues that you've opened up with, access to mental health. But maybe you could talk a little bit about giving your perspective as a psychiatrist and being in Virginia, and what some of the challenges are for accessing healthcare in rural health in rural areas where, most hospitals that are closing there. Most practices that are closing there. Just kind of what's the everyday challenges of folks who are working in rural areas to get access to care?
Yeah. John, I'm glad you raised this point because people need to have access and they need it when they need it. When you're struggling with a severe bout of panic attacks or severe depression or going through withdrawals from substance or alcohol or something that you want help getting off of, to me, that's a medical emergency. So people want care quickly. For physical health, you're having chest pain or severe headaches or something strange going on, you go to the emergency room. But for behavioral health, sometimes people think, well, this is behavioral health. It's not that urgent. But I tell people it is urgent. You need to have help quickly. There are in rural areas, as you said, very limited access to physical health. But I really admire my family medicine and pediatrician colleagues. They are on front lines in these communities across the country in these rural areas. But with the increasing shortage of psychiatrists and mental health professionals, coupled with getting them into the areas where they're needed most. And you're right, it's not just urban. There are urban areas that need us where we serve, but a lot of rural areas across the country, getting you in there and getting you in front of patients quickly. That's what we work on. It's a challenge. People have to work. Their kids are in school. They have to have babysitters or things while they go to appointment. And those are financial challenges, transportation challenges. Car breaks down that day, and then your appointment is pushed back 3 months. These are the real sort of what we call social determinants of health, the factors that are real things in people's lives that impede them getting the care. So what we have to do is keep trying, keep being on the front lines with folks, keep being respectful of them and their need, and being available as best as we can.
I just think what you're talking about is so important given what we've observed as the acute kind of growth of loneliness and the real isolation that often goes with being in a rural community and get those issues of access, where I think that mental health, some sort of mental health support, if not intervention, would be kind of essential to kind of navigating the challenges that are exposed, I think, to everyone during COVID, during lockdown, and that sense of being isolated or disconnected. That's kind of the everyday reality for folks who are living at a pretty great distance to urban and suburban centers.
Absolutely. And we can't blame patients for not getting access to the care that they need and that we can offer. Telehealth has created, it's not a new technology. The VA and other systems throughout the country have been doing telehealth for many years, but the changes that were implemented by CMS, so Medicaid and Medicare, during the pandemic, allowed us to reach into communities and clinics that we wouldn't have been able to before. And the growth of telehealth, going from really expensive cameras and all this digital equipment that people said you need, to working with, like we are, with a simple camera or working on your phone, on a tablet, whatever people have, wherever they can get access to data or Wi-Fi, making it simple so that we're breaking down those very real barriers that people have to getting care. Loneliness is real. It really is. And so, and particularly with mental health, you hold a lot inside, you're scared to get help. So creating avenues where people can break through that loneliness and get the help they need in a timely manner through a portal, through a connection.
That's the great thing about telehealth is you start to get, for all of us, I think it's a challenge to admit that there may be an emotional thing going on, or you might be upset about the loss of a spouse or a child or a dog, whatever, that things are difficult. To be able to provide real-time access through the avenues of communication that we otherwise use, that's a major breakthrough that I think that, to your point, CMS has allowed with telehealth. Do you think you can provide I don't think we've got much of a choice given how many people have needs, and there aren't enough of you, Tom, sorry. But how successful can you be in connecting over an iPhone or a tablet? Do you feel that you and your colleagues at Iris are breaking through and really making a difference in people's lives and lifting them up?
Yeah, absolutely, John. I mean, it's something I learned early on in psychiatry. 6 months into my own private practice in North Carolina, came home and said to my wife, I could create 10 more of me, because the need was tremendous. And I had a lot of colleagues working around me, but particularly when you're working with underserved populations and children, the elderly, people that are often disenfranchised, people who are incarcerated, homeless populations, folks that a lot of folks that really struggle with additional social determinants of health, the need to connect to them and find creative ways that work for them is imperative. Because what we learned during COVID is we can't just wait for people to come into our buildings, to our bricks and mortar, to our clinic and say, hey, I'm here, I need help. We have to go to them. And CMS, the DEA created avenues to make that easier and better and safer with less restrictions. And what the data has shown is that it works incredibly well. And certainly, who doesn't like going in person and seeing a therapist or whatever, seeing a doctor? But say you're in an area where you have to drive an hour each way, and you're a physician or a nurse or a therapist that has to drive an hour each way or 2 hours. It is just amazing the burden that's on people. So it's really a no-brainer to make telehealth the avenue where people can access care more quickly. But patients are in the driver's seat. They get to choose. So if they want to drive and go literally in the driver's seat and go to a doctor's office, that's great. Like, I don't know if you've had experiences recently, but many primary care docs and mental health professionals will say, do you want to come in person? Do you want to do through tele? What works best for you?
It's a game changer, although I will say that the healthcare establishment took a long time to actually make it easy, and it was only a crisis that made it available. So tell me a little bit about, tell our listeners a little bit about Iris and kind of what you guys are doing to kind of expand access and reach, and what kind of
Yeah.
impact are you having in people's lives?
Yeah, I appreciate you asking that because, you know, people say, how can you be a psychiatrist? And sometimes I say, how can you not be one? And they say, what do you mean? And I was like, every day, myself, others, my colleagues were invited into the intimate parts of people's lives where they're really struggling, really hurting, dealing with issues with their children or with sick loved ones or their own mental health issues, really struggling. And to be able to provide that kind of care, yes, it can be exhausting. It can be draining, like many things people do for work. But at the end of the day, I can say to myself and our colleagues do that we're trying our best to help people. We're trying, and that's meaningful. Iris started in 2013, really as a response to community mental health needs in Virginia. My colleague, Dr. Shaheen, a great psychiatrist, just helping out community mental health centers that needed it, and then more needed it, more needed it. So he began this business and started off small, grew it from there, just in Virginia to now we're in 44 states across the country. The same model was there, that you respect the dignity of every person. You share their journey, where are they, what are their needs are, and then you try to guide them to the right level of care. As I said, some talk therapy, art therapy,
And is Iris more of a business to business provider that an employer would hire Iris to take care of its employees, or do health plans hire you guys? I mean,
yeah. It's a really interesting question because there were some concrete decisions we made. We don't have our own hardware that you have to buy to access us. So we work in community mental health. We work with FQHCs, so federally qualified healthcare centers that are serving folks with physical and mental health and addictions, residential treatment. So we made connections with those organizations. Our providers get their credentialing panels on their insurance. So they're working for Iris, but they're also working for our health partners. Some
so
have one Iris.
you're basically creating infrastructure that those healthcare institutions don't have to extend mental health access.
Absolutely. And it's so cool because they might need one psychiatrist or one therapist. Some places we have 30 of us working there. Some places where the entire Department of Behavioral Health for a healthcare organization or health system. So to be able to come in and not just say, this is the way you have to do it with Iris. We listen to our partners, large health systems, hospitals, clinics. What do you need? We talk about how they're serving their community, what the unique challenges are there, and work with them to design something that's good for the patients, good for the clinic. But you also have to take reimbursement seriously these days and factor that in.
And so let me roll the tape back. So Iris is available through these systems. You're creating the muscle, the psychiatric muscles that a lot of these institutions lack to provide the resources. Turn it around to the patient level. A lot of patients have a hard time taking that first step. What's your advice to a patient that may be bothered by something going on in their lives emotionally, or that isn't quite sure that they want to take the first step to go into an institution or make a phone call or make a video call and ask for help? What do you say to a patient who may be on the bubble, may be concerned about any stigma, or concerned that maybe they don't fit in the system, or their problems aren't ones that a normal doctor can solve? What do you say to that patient?
Yeah, it's a wonderful question, because that's where a lot of people are. They're thinking about, do I take that leap and talk to somebody? Do I open my heart? Do I open my mind to a professional and invite them in to help me? That's it's a challenging thing to do, just to take that initial leap. And what if you take it and then you say, okay, we'll get you in with somebody, they're 3 hours away and there's a 6-month wait list? It's really disappointing. So you feel like you opened yourself and then there wasn't access, or the only access is to go to the emergency room, or you have a cry for help. You say, I'm having some suicidal thoughts, and then you have police at your door, taking you sometimes to handcuffs into the hospital. Things that communities do to try to prevent people from self-harming. Um, the first step is creating these networks, working with health systems so that they can advertise to their patients, so that the payers that those patients are working with, whether they're Medicaid and Medicare or Blue Cross, whatever, they can reach out to those patients, send them texts, send them emails saying there are mental health providers there, they're available to you. Iris is partnering with us. We can provide this service. There is not a long wait time. We can get a diagnostic evaluation done usually within 3 to 7 days. After that, we can get you plugged in with a therapist or a psychiatrist or nurse practitioner within 3 to 7 days.
So Tom, that's amazing. But what do you say to the patient who's afraid to take the first step?
Yeah.
To get help?
It's I tell patients a lot that I'm treating in the hospital, particularly when they're really unwell, that I'm proud that they came in, because I know it's hard to make that decision. And so through people like that, I think word of mouth, if you can tell someone, I'm proud of you for crying for help. I'm proud of you for making this step to call 911 and come in here. I'm proud of you for making this appointment today. I think that's where you begin, is acknowledging how hard it is to reach out and just make that first step. I think there's a lot of people waiting, so we can't make that step for them. But the more that we can connect with communities at the community level, whether it's faith organizations or community mental health or community health centers or homeless shelters, that they can say to their folks that are there, hey, if any of you are struggling with addiction or mental health or some issues, there is help for you. People store that in their mind. And so when something comes up, instead of saying, no one will help me,
you're making sure that door is available for someone when they need it.
Absolutely. Absolutely. And it wasn't as available. COVID has really created some scenarios where more doors are available. And I do find, I'll tell you, John, it's exciting because more people are willing to get help than before.
Which is amazing, because we do have an epidemic of mental health challenges and suicide, self-harm with veterans. We've got an epidemic of self-harm and suicide among young people, particularly young women. And I think it's even more essential right now, the services that you, Tom, and Iris are providing.
Yes.
What's your point of view? What's your view of AI chatbots that some organizations are using to extend access to folks, leveraging technology effectively on its own to help people with mental health challenges? Are you for or against those chatbots?
I will tell you, I'm for good chatbots, and I've been studying them for about the last 15 years, the technology, how they communicate. Because as I said before, when I was first in practice, I told my wife I could produce 10 more of me. I love what I do. I love the work I do. I'm glad to have colleagues around me that love the work we do. We could all make 10 more of us, but that's not going to happen. What's the next best thing? Next best thing is having patients feel held by something. You talked about loneliness. Can you make a connection potentially through a bot? And sometimes just calling and making an appointment with someone, and you made an appointment on the phone and you talk to a scheduler. Well, you've made a connection. Someone has listened. Someone has put me in a queue, in a schedule. And so something has happened. That's the first step. So I don't fear bots that can help with basic things like scheduling and not just press 1 for a schedule, press 2 for billing. It's like we find with like ChatGPT and others where they're conversational. Tell me why you're calling today. It's been interesting. I'll tell you this interesting story. I was on doing a training for my hospital and talking to this person. And at the end of it for 30 minutes, they said, by the way, maybe some of you have realized I'm a bot. I'm not a real person. And I do not. I could not tell, except that the guy was much younger and much smarter than I thought. A young person? He was like 18 or something. But I think that's the thing, is that it's the type of bot. And I don't fear it. I was at American Hospital Association in Nashville earlier this week, and everybody's talking about how to implement it into the work queue to create efficiencies. And what do efficiencies do? It allows providers, doctors like me, to spend more time with patients, less time having to gather a lot of records and data and labs, but have that information come in, be some.
Every doctor would be happy to be done with it in this trivia. But effectively what you're saying, Dr. Tom, is you're good with artificial intelligence and chatbots as long as they meet a standard of connection and competence.
Absolutely. I see the data and I see people have fear about it, fear of trust, but you have to show people that a bot or some type of interaction with an AI can be trustworthy. And I think that's the journey we're on right now, is it showing that it's not just going to, spit out things or make, you ask it for how to commit suicide or things like that. And it's going to tell you there's going to be smarter and smarter bots. So there's some caution around the data that's behind them. But in terms of things like AI companions that you can talk to and interact with, that they know you, they know everything about you in terms of what they see. There's not as much to fear there. I think there's a lot to celebrate.
Let's finish then on those two components of the three components of hope: access, connection, and the possibilities of technology. Dr. Tom, thanks for joining us. Really appreciate you joining Caretalk today. And for our listeners, if you like what you heard or you didn't, we'd love you to subscribe on your favorite service. Dr. Tom, thank you so much, and congratulations on everything you guys have accomplished at Iris.
Thank you, John. Good to be with you.
Cheers.